See, the topic of hypothyroidism itself is a vast thing, so we can discuss many things. So I will try to go through some illustrative cases so that we can discuss some points. So the spectrum of thyroid disorders as a clinical practitioner, so be it a general practitioner or a specialist or a pediatrician or a gynecologist, you can come across a wide spectrum of thyroid disorders, including the hormone dysfunction. You have hypothyroidism, which is an underactive gland, hyperthyroidism, which is an overactive gland, or you can have some structural problems in the gland. So it can present to you as a goiter or a thyroid malignancy. So each needs some sort of pick and go type of investigations and management. So today we will concentrate on hypothyroidism. So this is one of the most common endocrine disorders. As specialists also we see that, and it's often underdiagnosed in the general practice setup because of the, as Sir told, the symptoms are quite non-specific and very subtle. So sometimes they may come with some vague symptoms. You may pick up or you may not even think of hypothyroidism in that setting. The hidden burden, the term lies in the fact that though the prevalence is very high, it's not often diagnosed in many cases. And the incidence of hypothyroidism is slightly higher in iron deficient areas, though the problem of iron deficiency no longer truly exists. And interestingly, it afflicts all age groups from neonate to geriatric population. No age is immune to hypothyroidism. The prevalence is somewhere between, say, 0.25 to 4.2 worldwide, and we live in an area where the incidence of or prevalence of hypothyroidism is quite high. And with the advent of the general health checkups and laboratories offering packages, we now tend to overdiagnose the incidence of thyroid disorders, be it overt hypothyroidism or be it subclinical disease. Indian studies have shown that compared to the worldwide data, the prevalence across the zones of India is significantly on the higher side, somewhere between 10 to 12%. And the data from the western states, particularly the West Bengal, had shown a higher prevalence. And as with any other data, the prevalence rate is much higher in female population than in male population, though various theories exist why this sex difference occurs. The basic hypothalamic-pituitary thyroid axis works like this. The TSH, the TRH and TSH from the hypothalamus and pituitary respectively, they act on the thyroid gland to produce or stimulate the secretion of thyroid hormones, T4 and T3. T3 is the active hormone which acts at the tissues, but T4 is the predominant circulating hormone. So it is available as a free hormone as well as bound to certain proteins. Because of the negative feedback, this goes in a regulated fashion. So whenever there is an excess production of T4, it causes suppression of TRH and TSH so that the homeostasis is achieved. Whereas a deficiency of T4 stimulates the production of TSH. So this forms the basis of your biochemical testing and interpretation of thyroid function test. So the basic thyroid function test, you would have seen in your lab reports, which includes T4, TSH and T3. T3 is very rarely used for interpretation of thyroid dysfunction. So we use it only in limited conditions. All you need is a T4 value and a TSH value. So as far as hypothyroidism is concerned, you concentrate only on those areas where the T4 is low. Be it primary hypothyroidism or secondary hypothyroidism, the basic problem is the T4 is low. And because of the feedback mechanism I was telling, in primary hypothyroidism, the TSH is high, whereas in secondary hypothyroidism, the TSH can be normal or low. A combination of low T4 with high TSH, primary hypothyroidism. A combination of low T4 with normal or low TSH, you have to think of secondary hypothyroidism. Secondary hypothyroidism by means it's either a pituitary or hypothalamic dysfunction. And do you screen everyone? It's again a debatable topic, but generally we suggest selective screening because universal screening leads to more overdiagnosis because there is no standardization of the testing methods across labs. So you tend to overdiagnose subtle issues and tend to overtreat people, creating unnecessary anxiety to the patient. So you screen for high risk population, particularly when the age is more, You have people in reproductive age group who have a family history of thyroid disease. There is a goiter, and there is another autoimmune disease like type 1 diabetes. We routinely screen for thyroid dysfunction. And in other autoimmune diseases also, you can go for thyroid screening. For example, if you come across a patient with vitiligo, obviously the chance of them having a thyroid dysfunction is high, so you can screen them. So our suggestion is go for selective screening, don't go for universal screening. So let's go through some clinical cases. I would just go through some unusual and uncommon conditions causing hypothyroidism, which is not often seen in clinical practice, and or the diagnosis is pretty delayed. So this is a straightforward case. A middle-aged female presenting with symptoms that are very suggestive of hypothyroidism: weight gain, fatigue, cold intolerance, and menstrual disturbance. The typical menstrual disturbance with hypothyroidism is menorrhagia or increased menstrual flow. So clinical examination shows puffiness because of the water retention and a diffuse goiter. Usually the goiter in hypothyroidism is a diffuse one. Investigation shows a total T4 of 4.5, which is less than normal reference range. Usually it is between 6 to 12. TSH is high, so the diagnosis is a primary hypothyroidism. And the antibody titer against anti-TPO is more than 600, which is quite significant. So all these suggest a primary hypothyroidism in this lady, etiology being autoimmune thyroid disease. So this is a list of common causes of hypothyroidism. The most common cause we see in clinical practice is autoimmune thyroid disease. And the marker for autoimmune thyroid disease is anti-TPO antibodies. Anti-TG antibodies is often done in many clinical practice, but they do not point to a specific disorder, because anti-TG antibodies can be normally seen in quite significant number of healthy population. The other common causes which we come across is post-ablative, either surgical or post-iodine therapy. Iodine therapy is usually used for treatment of thyrotoxicosis due to Graves' disease. So post-iodine therapy, people invariably develop hypothyroidism. One commonly ignored cause for hypothyroidism is radiotherapy. So with more and more people getting diagnosed with the early head and neck cancers and the survivors being in increasing number, those receiving head and neck radiation invariably develop hypothyroidism during the course of the management. Iodine deficiency is a very rare cause. Infiltrative disorders again is a very rare cause. We see lymphoma involving the thyroid gland, which can present as hypothyroidism. Dysgenesis and dysharmonogenesis are usually limited to pediatric population. So this a word about post-RT hypothyroidism. So it typically presents after a course of radiotherapy for head and neck cancer. The median duration of development is between, say, 1 to 2 years. So it is generally advised to actively screen them for development of hypothyroidism every 6 months after the last dose of radiation, because we often see in our clinical practice that they present very late with symptoms of hypothyroidism, and those symptoms are attributed to other causes. So in a patient with hypothyroidism, once you've diagnosed, how do you go about? Treatment, the gold standard is levothyroxine. So the levothyroxine sodium was introduced for clinical use maybe 75 years back, and after that there is no looking back. And as Sir was telling, though we easily diagnose hypothyroidism and the treatment is as simple as giving a tablet to the patient, many a times to achieve and maintain clinical and biochemical euthyroidism in these patients can be quite challenging due to many reasons. And the ease of administration is that it can be given once daily. In between, weekly once thyroxine came into use, but that was not very popular among both physicians and the users. And levothyroxine sodium literally doesn't have any side effects. The common question asked by our patients is that, the maathirukku edha side effect unda sir? That's the first question they ask. So literally these drugs do not have any side effects unless they are consumed in abnormal quantities. So titration is quite individualized based upon the age of the patient, the weight, and other clinical conditions like catabolic state or pregnancy. So the aim of treatment of hypothyroidism is to normalize the thyroid function or homeostasis. So you try to bring down the TSH to the normal range and try to maintain that. Generally advised levels of TSH is somewhere between 0.5 to 3. So up to 6, maybe you can take it granted. And the typical dose we use in adult is 1.6 microgram per kg per day. You start with that dose. So for example, somebody who is 50 kilograms, you start with 100 micrograms daily, and then up titrate the dose or down titrate based upon the further testing. But in elderly people who are more than say 80 years, or who has underlying cardiac disease, who had a recent acute coronary syndrome, a higher dose can precipitate a ischemic event again. So you try to give them a lower dose and then gradually up titrate the dose. And monitoring, you reassess the thyroid function after 6 to 8 weeks of initiating the thyroid medicine, because it takes at least 6 to 8 weeks for the homeostasis to be achieved. So you know that the half-life of T4 is around 21 days. And once a stable thyroid function is achieved, all you need to do is monitor the thyroid function only 6 months to yearly once. You don't need to do it repeatedly every month. Or I've seen patients bringing reports being done every month or so, and then keep on titrating the dose based on the reports. Pregnancy naturally requires a higher dose because of the changes that happen during pregnancy. And generally, we adjust the dose much earlier in the pregnancy. So any abnormal thyroid function during pregnancy can result in increased pregnancy loss if not done appropriate. And few pointers here. So there are many drugs and food that can interfere with the absorption of thyroxine which you give. The most important point I stress to my patient is the intake of soy protein. So there are patients who regularly take health drink with now body weight management is coming into vogue. Many people are taking meal replacement, which has health drinks that are mainly based on soya protein. So when they take in higher quantities regularly, that can interfere with the absorption of thyroxine, and that can result in suboptimal control of hypothyroidism. And there are other agents which are not very common. And the common question our people ask is whether usage of cruciferous vegetables like cabbage, cauliflower, or radish can affect your thyroid function. But generally, it's not so. So regular intake in a raw form daily over a period of months can interfere with your thyroid function. Otherwise, once in a while, well-cooked food do not usually cause any problem with the thyroid function. And many drugs which you use again can interfere with your thyroid function testing and the thyroid hormone levels and action. So you have to have a eye for all these medications when the patient is taking thyroxine. And hypothyroidism in children requires a special mention here, because as a general practitioner, you may be seeing adolescents and children as well for their minor ailments. And one of the common presentation of hypothyroidism in adolescents and children is short stature. So any child who is not up to the, whose height is not up to the age, always check for a simple cause like hypothyroidism, which is quite treatable. And this is a patient who had been following up with me from childhood. As you can see that the height which was less than third centile, after proper treatment, is almost reached the normal height. There's another child with a dysgenetic thyroid. As you can see that the lingual thyroid, which is at the base of the tongue, usually these thyroid glands do not function normally. They are not able to produce enough thyroid hormone. So they present with hypothyroid symptoms much late in the life. It's not that they present at the neonate or early in their childhood. And this is a recent emerging causes for hypothyroidism, where you can see that use of immune checkpoint inhibitors. These are used for treating malignancies, or they are called targeted therapies. They are targeted against certain immune regulatory proteins, and because of the loss of immune tolerance, there is destructive thyroiditis which results in hypothyroidism. So we see a quite number of people who are on these drugs developing hypothyroidism during treatment. So this hypothyroidism, though it is destructive thyroiditis, unlike the viral thyroiditis which we see, the hypothyroidism here is more often a permanent thing. So most often these patients require lifelong thyroxine replacement. And This is a story of a 42-year-old male who presented with 10 years, is a very long history of fatigue, lethargy, and he has been roaming around with multiple consultations, though no appropriate diagnosis could be made. Recently, he had consulted a physician who did a thyroid function which showed a low T4 and a normal TSH. So here the diagnosis, your suspicion should be something not primarily related to thyroid gland, but something related to the pituitary or hypothalamus. So subsequent tests also showed the cortisol and gonadotropins were low. So making a diagnosis of panhypopituitarism. And as a part of panhypopituitarism, there was hypothyroidism. And the MRI showed a empty sella. For comparison, I have put a normal pituitary there. So as compared to that, you can see that the sella is quite empty here. And the coronal section also shows the sella to be empty. So this is a typical case of secondary hypothyroidism. And further exploring, he gave a history of snake bite 15 years back. And the snake bite is a Russell's viper, which is a hemotoxic snake bite. So a Russell's viper bite can sometimes lead to hemotoxicity resulting in acute kidney injury. All these hemodynamic problems leads to pituitary insufficiency, which can happen early or much late after a snake bite. The people, they forget the snake bite and they present much later. And the management is again simple through thyroxine and with replacement steroids. But the only thing in secondary hypothyroidism is that you always check for their cortisol axis before you start them on thyroxine replacement. So without cortisol replacement, if you put them on a full dose of thyroxine, you may precipitate an adrenal crisis in them. And the last one is a middle-aged male who was diagnosed with hypothyroidism 5 years back. He had been on stable thyroid function for past 2 years, but of late, he had, the thyroid function shows very fluctuating levels of the hormones, and the recent TSH shows 30 MIU per liter, which is quite high, despite being on the levothyroxine replacement. So the possible reasons for persistent elevation, despite being on treatment with thyroxine, includes the most common thing is non-adherence. So you keep checking. And if you're not sure about it, you ask a family member to give the thyroxine under their supervision. So it's a simple step. You ask somebody to monitor whether they're taking the thyroxine or not. Drugs and food. This patient particularly, he was indulging in workouts in the gym, and the gym trainer had advised him some protein supplements, which predominantly had soy protein, and because of that, his TSH was high. So once that protein supplement was stopped, the thyroid function normalized. And there are other causes listed here. And we also keep in mind that when you are in doubt or the TFT shows subtle abnormalities, you always recheck with the proper method or from a different lab, because a single subtle variation can result in unnecessary investigations like a thyroid scan or even starting anti-thyroid drugs. For example, somebody is on a biotin for hair loss, the free T4 assay can be high. So patient may be asymptomatic. So as a part of hair loss, the physician might have done a thyroid function test, but if the patient is already on biotin, the free T4 can be falsely elevated. And we have seen patients being started on anti-thyroid drugs for these reasons. So finally, as I was telling before, why hidden burden? Because the symptoms of hypothyroidism are very, very non-specific. The only specific symptom of hypothyroidism is thyroid swelling. So apart from this, most of the symptoms are not very specific. So subclinical cases may be missed in clinical practice, but paradoxically, with the advent of the patients consulting artificial intelligence over the web and labs offering packages, the thyroid, subtle thyroid dysfunction are being overdiagnosed. And the solution is again to create awareness among ourselves and among patients not to overdiagnose or undertreat. So when to refer to a specialist, these are some indications. When you are not sure about the diagnosis or the optimal dosing of thyroxine, you can get a specialist help. So thank you for